Welcome to this Nursing Times webinar on enhancing your continence skills. My name is Steve Ford and I'm the editor of Nursing Times. To coincide with World Continence Week taking place in June, we have created a series of 5 free webinars which are supported by an educational grant from Essity. Designed to provide general nurses with accessible educational content, this series is designed to help you to develop your practice and improve the quality of continence care delivered to patients. Across the series, our expert contributors will explore the following key principles of continence care: male incontinence, continence and transgender people, children with complex needs and transition to adult services, acute stroke and transition to community services, and how digital technology can help improve access and support the care of patients with continence problems. Each webinar will feature an expert nurse who will provide a clinical update on these important themes, followed by a question and answer session. You will be able to watch back each webinar afterwards or catch up on any that you have missed. In this webinar, we'll be exploring male incontinence, and our guest speaker is Ruth Broom, Urology Specialist Nurse at Norfolk and Norwich University Hospitals NHS Trust. Thank you again to Essity, and now over to Ruth.
Hello, my name is Ruth Broom and I'm the Continence Service Lead for Norfolk Community Healthcare Trust, and I'd like to thank you for inviting me to come talk to you today about male incontinence and male continence. So I think as professionals, we all know that male urinary incontinence is a very underestimated condition with health care, often unaware of the risk factors that are involved in male incontinence, and more often than not unsure of how to address the symptoms that these gentlemen are suffering. It's well understood that incontinence has a negative effect on quality of life, and although most research out there does focus on female incontinence, and I do think that men get a little bit forgotten, especially for the elder gentlemen, where later in life incontinence tends to get a little bit normalised. I've heard it myself from gentlemen talking between themselves and from healthcare professionals, when they have some nighttime frequency or that small post-micturition dribble, but they're told that it's normal for your age and it's to be expected. But it's not, and there is help out there for these gentlemen. We can improve on their quality of life with regards to these issues. There are some small studies that look at gender differences and how incontinence is experienced between men and women, but they do all tend to suggest that we do need a more targeted assessment in order to assess what is required from these gentlemen. Next slide. So what do the studies tell us? There has been systematic reviews, and they're a few years old now. There's one from 2009 that found that there was a steady rise in the prevalence of incontinence, from being 5% in younger men, 11% in the under 65s, and this does raise to 21% in the over 65s, with it reporting that around 9% of men aged 65 and over were experiencing daily episodes of incontinence. Excellence Incontinence Care, a little bit more up to date in 2018, tells us there's an estimated 14 million adults in the UK that live with bladder problems, and around 6.5 million have bowel control problems. Children, 900,000 children and young people are also expected to be experiencing symptoms, and again, that doesn't break down into male and female within those numbers. But if we think that 1 in 3 people in residential care and 2 in 3 in nursing homes experience bladder and bowel incontinence, with our ageing population, male urinary incontinence is going to be increasing by around just half as many men as it does women. So around a third of those figures is going to be from males with incontinence issues. NHS England have also cited studies which showed that 1 in 3 older men experience bladder problems, but also 1 in 10 children and young people in the UK experience bowel and bladder problems. There is a lack of information about incontinence in boys and young men, with studies regarding to male incontinence, mainly in those older generations, and probably most likely related to post-prostatectomy incontinence. But we do need to remember that in childhood incontinence, 6 amongst the most common long-term conditions, and Buchanan did discuss that back in 2009. And I think, again, there is a mistaken belief sometimes that problems are likely to resolve with age as the child grows, but it can lead to young people concealing their problems and causing delays in their treatment to help with their incontinence. I think we all know that bladder and bowel problems are common and affect males and females of all ages. However, among healthcare, within the general population, it is still widely seen as a female problem. And there is a risk that male continence guidance and research on male incontinence and its causes and managing continence needs for gentlemen are being or at risk of being quite neglected due to this belief, and that it's thought that male incontinence, although is becoming more increasingly common, and I think that's because we're just looking more, and obviously you've got an ageing population. It is burdensome and it is producing a significant impact on patients, their families, and within healthcare itself. It's been less thoroughly investigated than incontinence in women, but due to the assumption that the male incontinence is less of a problem, I think it's not seen that it socially restricts men as it does ladies. Economically, looking for pads tends to be, advertised. You only see the adverts really for female pads on the TV, very rarely anything else. But epidemiologically as well, it is an issue, and it does have a significant impact on men, reducing their quality of life, with them, staying away from their daily activities and doing what it is they want to do for the fear of not being able to find a toilet and leaking and wetting their trousers in public. So we need to ensure that men do receive good quality continence care. Next. So if we look at the anatomy and function of the bladder, I don't want to seem like I'm teaching you all to suck eggs, but I do think for those people that are new to the world of incontinence, that if you look at functioning of the bladder and the micturition cycle, it really does help us understand and understand why people are incontinent, and to help decide on their continence management. So at the end of the day the bladder is a hollow muscular organ with 2 main functions, and that is simply to store and to expel urine. It spends most of its time in the storage phase, storing urine as it arrives from the ureters, and during this time the bladder undergoes a receptive relaxation in order to accommodate urine, so that the muscle stretches and keeps the pressure down within the bladder as the bladder fills. And during this time, the urethra and the sphincter mechanisms will be closed, making us continent, and there is a higher pressure of that outlet and resistance to keep us dry. In the male, there are two important sphincter mechanisms. There's the bladder neck, or the internal sphincter, which is providing the mechanism to remain continent, to prevent retrograde ejaculation during sexual intercourse. It is a smooth muscle, and it is continuous with the detrusor muscle itself, and it is under involuntary control, or what we call an autonomic control. The external sphincter, or the distal and urethral mechanism, is a striated and skeletal model, and it sits at the base of the prostate and is under more of a voluntary control of the somatic nervous system, and it's capable of sustained contraction to maintain continence. And this is the muscle that when we ask men to do their pelvic floor exercise after prostatectomy, we know that exercising this muscle can strengthen the sphincter and help men regain continence. The two sphincters themselves do they are competent mechanisms within themselves and should maintain continence. So often, if one is damaged, the other one should be able to maintain continence for us. The prostate gland is the long male urethra, add resistance to that bladder outlet. The prostate is made up of a smooth muscle and glandular tissue. Increasing in age is known as a hyperplasia, and what we commonly call a benign prostatic hyperplasia, the BPH, which I think sometimes for poor men, the prostate does get a lot of the blame for their incontinence. Neural control of the lower urinary tract is via coordinated central pathways, and the storage phase is under sympathetic control, with the voiding phase being under a parasympathetic control. So we need that neural control to function in order for us to be able to void, store and void correctly. The bladder does have afferents in the hypogastric nerves, in the pelvic nerves, and in the pudendal nerves, so that stimulation can lead to the contraction of the sphincters, and in contrast, the pelvic nerve leads to the relaxation of the sphincters. So when we're assessing these gentlemen, it's important to look at whether there are things that could have been in their history that can have affected these controls. And equally, the detrusor muscle is relaxed by sympathetic system and contracted by the parasympathetic system. So if there is an interruption, not only will the sphincters not function properly, but the bladder muscle itself won't contract properly. Next slide. So urinary incontinence has been defined internationally. The International Continence Society sets the standards for the terminology as we should use. As you can see here, there are lots of types of urinary incontinence that they've defined, but we can't discuss them all today. But the most common male symptoms are those of urinary urgency incontinence, stress urinary incontinence, and mixed urinary incontinence. I have, a bit later in my talk today, also just added in the disability-associated incontinence, or what we used to call the functional incontinence, because I think in practice, especially here in community, functional incontinence does play a large part of our assessment, especially for patients in care homes. And functional incontinence, it is about, there's not often, or there isn't any abnormality within the lower urinary tract symptoms. This is all cognitive and physical inability for people being able to reach the toilet. in practice, it's often the case that patient presents with features of more than one types of incontinence, and especially post prostatectomy, probably. Where they've got some overactivity and frequency urgency symptoms just because the bladder's not under that much pressure to empty anymore, but the sphincters are a little bit weakened and they need to. So what we would normally work on is that we treat whichever symptom is most bothersome to the patient to start with, and work from there. So next slide. If we look at gentlemen when they present with urinary incontinence symptoms, they do need to have detailed and history and physical examinations. Initial assessment in the community aims to identify any urgent or reversible causes. So first line investigation should include looking at things like frequency void volume charts and post void residual checks with an ultrasound, and of course an MSU should be attained if they are symptomatic of a urinary tract infection. Medical history is often sufficient to identify lots of the predominant problems, the type of incontinence that they experience, be it urgency, leakage, nocturia, for example, and the impact that this is having on the physical and psychological well-being of the gentleman. It allows us to see how much of a bother, we hear bother a lot in the world of continence, how much of a bother their symptoms are for them. The presence of other lower urinary tract symptoms such as voiding difficulties and terminal dribbling, they can also help with a diagnosis. The amount of urine leakage, the number of and the type, not just the number of pads that they're using, but the type of pads that they're using, because we do know that men will sometimes use sanitary towels or use their wife's incontinence pads, but pads have different absorbencies, so using 2 sanitary towels as to using 2 big absorbency pads are very different in managing their expectation and their leakage problems. So it's looking at those sorts of things, looking at their coping strategies and and what they've developed on their own, because they will have all developed. Everybody knows that people with bladder problems does toilet mapping. They don't go around the city or they don't visit places where they don't know where the toilet is. So we need to ask them about how they're managing things at the moment. We also need to think about looking at surgical histories and drug histories of these gentlemen, to see if we can identify if there's any causative factors for their bladder symptoms. I don't know about you, but I've often seen people who've been referred to the continence clinic with frequency, and when you're talking to them, they only have their symptoms in the morning. It's because they take diuretics, and no one's actually explained to them that this is because of the diuretics. If you sit down and just talk to them about why it's important for their heart and blood pressure management to continue to take this medication, this is a side effect of that. And you say to them, I bet you by lunchtime the symptoms have all settled down, and they'll say, yes, it's only in the morning. We can it's just sometimes about managing their expectation. And I often say to patients, if you do want to go out in the morning, you've got an important thing to go to, you need to, there's something you need to do that you really have to do in the morning, go and do it and just take your diuretic when you get home, so you get those frequency and that diuresis later in the day. That shouldn't make too much of an issue for people, but sometimes it's just about teaching them to understand how their medications work and why this is affecting their bladder. And alongside with talking about their surgical and drug histories, we should also be just checking that there is no associated fecal incontinence along with urinary incontinence. Examination of these patients is important, and We do need to examine the abdomen and the pelvis and the external genitalia, and digital rectal examination and palpation of the bladder after voiding, just to rule out any residual urine. And I think we have forgotten sometimes that we do actually need to touch. We forget to touch the patient. But everybody does a bladder scan when actually, if somebody's in chronic retention, you can definitely feel that on the abdomen. You do the bladder scan to just check the volume. But if you can't feel anything, you can do the bladder scan just in case it is something that's a little bit lower down. And I'm sure. You in your clinics will have seen patients. I've seen gentlemen for post-nutrition dribbling, and they've come into clinic, and no one's ever checked this gentleman's penis. And his post-nutrition dribbling, because he got phimosis, couldn't retract the foreskin. It was tight closed, and so when he was voiding, it was just going into the foreskin and dribbling out later. This poor gentleman, they obviously need to have circumcision, and that will resolve those problems. But because he then had to wait to come to a continence clinic from a GP clinic, it just delayed treatment for them. I was able to give him some pads to protect his clothes, but I wasn't able to resolve the problem. So we do need to remember that we do need to examine these gentlemen. Not just for checking for prostate cancer, but just to check that there isn't something very obvious that's causing their leakage symptoms. Examining patients also allows you to check if they're complaining of stress urinary incontinence. You can ask a gentleman, just like you can ask a lady when he's standing up, give you a cough, and like the girls, the boys will also still leak. Neurological examination is sometimes necessary. So if they're giving you a history of lower back pains or spinal injuries, disc problems, if they've got other neurological conditions, Parkinson's, things like that, sometimes we do need to do a neurological examination. We're not all able to do this in our clinics as nurses, but at least we can do everything else and arrange for them to see the doctor to ask if a neurological examination can be arranged to assess for incontinence. So following their examination, we do have to highlight the red flags, and there are red flags associated with urinary incontinence. Probably the biggest one is overflow incontinence, when gentlemen have got chronic retention of urine, and that this, strangely enough, the patient very rarely reports any voiding difficulties. It's probably just been found out that their renal function on their blood tests has gone up, or if they've been examined for something else and actually somebody's felt the bladder, felt the abdomen, thought that they're full. But it is quite, and it does need to be resolved. And so we catheterise these patients, because that high residual volume does put a high pressure in the bladder, which can cause some backflow and renal impairment, and that high pressure chronic retention. When you catheterise the patient, you'll see improvement in the renal function, but we do need to monitor those patients for the post-obstructive diuresis. So I think these patients do tend to perhaps be catheterised in secondary care rather than in primary care, so that the diuresis can be managed. Other red flags when you do a neurological examination are hematuria. So if you've got patients presenting with hematuria, urinary retention, and obviously symptomatic of a urinary tract infection, or presenting with urosepsis, we do need to manage these urologically, rather than just trying to manage their continence issues. So after initial assessments, we may need to be referring these patients through for specialist investigation, with cystoscopy, just to check for bladder tumours for people with hematuria and frequency, or urodynamic testing, just so that we can test that lower urinary tract function. Next slide. So when we look at, after we've identified those red flags, and we can go on to try and manage it. So like I said, the most common cause of urinary incontinence in men is urgency urine incontinence. And they present with a sudden strong desire to pass urine, but they can't defer. So these are the men, you can ask them the questions of, would you, if it was the penalty shootout, would you stay to see? If it was the end of the whodunit in the movies, would you be able to wait and see who it was? And if they're answering no, I've got to go, else I'll leak. This is urgency urinary incontinence. It is associated with or without leakage. So sometimes men's urge are just so strong, but they don't leak. But it is there. And in men, it is typically associated with bladder outflow obstruction and prostatic enlargement. We don't always understand the specific mechanisms behind why bladder outflow obstructions cause detrusive overactivity. But the physiology involved in the bladder contractions, they think it could be due to a defect in the afferent signalling from the urinary tract. And there's lots of things that we probably haven't got time to go into today as to urodynamically why this might happen. And we should also ask patients about other factors. Have they had previous pelvic surgeries? Have they had previous spinal injuries? Do they suffer from diabetes? Have they got hypertension? All sorts of things that the outcomes from those, the side effects, if you like, from those can cause their overactive symptoms. Age does seem to be an independent risk factor with overactivity, and studies have looked at how that does increase with age, but this is independent of other factors and is found in both men and women who obviously haven't got a prostate. So there's lots of different reasons that men could have overactive bladder symptoms. First line treatments for us are bladder retraining, looking at their lifestyle. Are they people that have always gone to the toilet frequently? Is it just that they've never truly filled their bladder up and now it's presenting as an urgency? Is it what they're drinking? Everybody looks at the tea and the coffee for the caffeine intake. Artificial sweeteners, we know, can stimulate bladder sensations. We know there's all sorts of foods out there that can also stimulate. So taking patients through looking at their lifestyle, looking at what they're eating and drinking, just to get them on a healthier lifestyle, telling them that it's okay to delay going to the toilet and gradually increasing that postponement time of actually going to the toilet will help improve those symptoms. But they do have to buy into that, and they do have to be consistent with it. You can't do it for a couple of hours once a day. It is something that needs to happen along with every urge to void to make things improve and have that biofeedback happening. If bladder retraining and lifestyle and diet, fluid management don't help, we can look at the anti-cholinergic therapies or the beta-3 agonists as tablet therapy treatments in order to help with those overactive contractions. And where that fails, more commonly now we're looking at Botox injections and then moving through into neuromodulation to help modulate those nerves so that the overactive contractions aren't happening. Bladder outlet obstruction, as I said, has been shown to be a cause of overactivity, and studies have demonstrated that there are several mechanisms by which that can happen, but it's thought that prostate surgery for enlargement will actually relieve around 70 to 80% of overactive bladder symptoms post-operatively, but it can take a few weeks for that to happen. They might initially think that after their operation it's all failed, but it usually will settle. Next slide. Having said all of that about overactive bladder and stress and the prostate and being blamed for everything bladder, stress urinary incontinence is almost always after prostate surgery, and especially with radical prostatectomy, with incontinence rates ranging between 10 and 25%. Understanding how urinary incontinence develops after radical prostatectomy is still developing, but it's thought to occur because of damage to the urethral sphincters. However, there are schools of thought that think there are other issues to do with urethral length and things after the radical surgery, but it does seem that with the advent of robotic prostatectomy, the incontinence rates are definitely better. But we do need to teach these gentlemen how to do their pelvic floor exercises, and I think it's important that they're taught to do this preoperatively, so that they learn, one, that they've got a pelvic floor muscle. Lots of men don't know about it, but at least they've got good practice in knowing how to do their exercises before we do anything to go in there and damage it for them. It's like post baby for ladies isn't the time to be learning to do your pelvic floor exercises. Get to know how it feels, how to do them before the event. If pelvic floor exercises aren't enough for gentlemen with stress urinary incontinence, though, generally, if there's been some big pelvic surgery that's gone on, we will normally wait 6 to 12 months before we go in there again investigating this. But your options would be urethral bulking agents, urethral slings, and artificial urinary sphincters to solve these issues for gentlemen. And as I say, there are other causes of stress incontinence. It's not all post-prostatectomy. Like I say, we need to know about pelvic trauma. We need to know if they've had pelvic radiotherapy, if there's been any back injuries or spinal injuries, and neurological disease. All of these things, when we looked at the anatomy, you can think how they affect the neural control. We need to be asking about these things. Next, please. So disability, I haven't gone through to talk about the mixed incontinence because, as I say, that they often become... you see the patients and they're complaining of both. You treat one, treat their urge symptoms or their leakage symptoms, dependent on which is most bothersome for them. But I think, especially in here in the community, disability associated incontinence or functional incontinence is what we do see a lot of, especially when we're going into the care homes, into patients' own homes when they're needing carers, and although it is an incontinence, it's not a lower urinary tract symptom. There's often not a problem with these patients' bladder or bowels. It's a result of something else happening to the mind or the body. There's musculoskeletal issues, there's neurological issues, there's cognitive issues. The patients, with cognitive problems will often know they want to go to the toilet. They've just forgotten where the toilet is, or they've forgotten that the signal is go to the toilet, and so they just let it leak. There's all sorts of things, but it's more to do without function, and get there. So the right approach for these gentlemen and ladies as well, obviously, but in this case for these gentlemen, is knowing their normal toileting routine. Talk to their relatives about, especially here in Norfolk, that there are men out there that had outside toilets, and actually during these periods of confusion, just don't know, are outside looking for a toilet to go to. When you've got people with cognitive problems, just having a different colour floor in their bathroom is enough for them to not recognise that this is the place where they go to the toilet. With regards to bowels, they might have only ever gone to the toilet once a week normally. So, just because we think they should be going a little bit more often, if that's all they've done all of their life, we shouldn't be making them go more often just because we think 3 days is long enough. So know their normal toileting regimes, and it will help reinforce for patients where they want to go. And looking at their physical barriers, is it due to the fact that they've got a walking stick and actually what they need is a frame? Is it because they can't get into their toilet and sit down properly, or once they're on the toilet they can't get back up again? And so we do need to involve the OTs and the physiotherapists in managing these symptoms for these patients to become continent again. Just because there's confusion and mobility problems doesn't mean these patients have to be incontinent. We don't have to just pad them up or catheterise them. Actually, with behaviour, they can remain continent, and it's a hard thing to do, and it's a hard thing to sometimes get across, especially to carers, that the patient can become continent again. Because it's a lot of work for them, and I fully understand that. And sometimes the easiest option for the carer is to have an incontinence pad. But as bladder and bowel health promotion, we should be able to, and we should be providing the means to make people continent again without just containing incontinence. Simple things like vision as well. I forgot about that. If somebody's got dirty glasses on, they can't see where they're going very well. If they need a new glasses prescription, or the light isn't very good in their bathroom. Things like this about getting a good environment is very important in making sure that people can remain continent. And like I say, involvement of the OTs and the physios at these points is absolutely the right thing to do, and they are the right people. They'll get the rails in, they'll get the lights sorted, they get the commodes sorted. So we do need to remember that there is this extension of our team. Next slide. So I think I've talked enough about urinary incontinence. Fecal incontinence is there's much less management options for patients with fecal incontinence, really, and it is classified. I did the classification of bladder incontinence, but fecal incontinence is the loss of stool, liquid, or gas from the bowel at an undesirable time. Females of any age can be incontinent of faeces, and it can occur at any age and may affect up to 1 in 10 people. And as with urinary incontinence, become more common as we get older. People experience incontinence of faeces. May have had injury, perineal injury, so it's damaged the sphincters. There may have been assault cases, and there are reasons why sphincters become damaged. Or neurologically, they just might not be working as effectively later in life, or if they've got other neurological conditions that are affecting, like the bladder, the neural control of the bowel sphincters, they will become incontinent. So we can look at that. It can occur following cancer treatments such as radiotherapy to the pelvic organs. If it's hit the bowel, it's likely to give them some fecal incontinence symptoms. Treatments, however, for fecal incontinence is fairly frequently successful. For the bowel to function properly, it does need the nerves of the rectum and the anus to be sending the correct messages to the brain, so that it can sense when stool or wind arrives in the rectum and can transmit messages to the brain to send the message back to tell the muscles to hold it in until it's a convenient and social place, toilet, or out of ear range of your colleagues if it comes to a passing wind. The internal and external sphincters do need to be working, and stools need to be not too soft and not too hard. Loose stool with weak sphincters is going to have fecal leakage. And if you've got hard stool and you've got muscle contraction difficulties, it's going to just make it harder to expel stool from the rectum. Next slide. So how do we diagnose? Most patients don't need formal testing. It's a careful history and examination will often give the information needed as to what sort of fecal incontinence people are experiencing. But if they do need tests, these are relatively simple. They don't need a lot of preparation, and they're quick to form, and they're usually pain-free. The strength of the muscles, the sensation within the rectum, and the nerve function, for example, can be tested using pressure monitoring devices, and manometry, anorectal manometry, you'll often hear it called, and then they're not too uncomfortable for patients. They're not too invasive, and they will help understand exactly what's happening, like urodynamics does for the bladder, for the rectum and for the bowel. Ultrasounds also can provide pictures about what's happening at sphincter level, and to see if there's been any damage to the sphincter muscle itself, which is why it's not functioning properly. If there has been a pelvic trauma, a perineal trauma, for example, so we can look at that with just ultrasound. Examination can be helpful in providing information about muscle and sphincter strengths, and there are increasing numbers of specialist nurses and physiotherapists and physiologists within specialist fecal incontinence units that will do these examinations and tests for us. So when we have established that there is a weakness somewhere, we would normally classify the incontinence as being urge incontinence, flatus incontinence, passive incontinence, anal rectal incontinence, and overflow incontinence, all with their own definitions, as you can see. I won't go through them all. Next slide. So fecal incontinence is embarrassing and it's inconvenient. Whereas you can try to hide a little bit more urine incontinence, it's much more difficult to hide a fecal incontinence, especially if it's been loose. Being in control and organised can help patients manage their day-to-day living and manage their symptoms. And they do put a lot of planning into it. They tend to know when they can leave the house, because if they've treated themselves, they'll know what time they're having their bowels open, and they know not to go out of the house until this happens, because they can't hold on to it, for example. Knowing how long they're going to be out, knowing where their toilets are, and they often take spare clothing, and do use products such as anal plugs, as long as they are suitable for use in the rectum at the time, or pads to absorb any leakage, to try and protect their clothes. And it's also important that for fecal incontinence, especially with liquid faeces, that we do pay a lot of attention to protecting the skin around the back passage and keeping it clean and dry. I'm sure we've all seen the Bristol stool chart in our lives, but just for anybody that it is a new assessment tool for them. It was devised to help us determine what is normal, and it's a visual guide that you can use really usefully with patients and ask them what does their poo look like, so that we can have a good idea on what type of stool they are passing, and so type 1 and type 2 would indicate that this patient does have constipation issues. Types 3 and 4 are normal, ideal stools, if you like, and 5 to 7 would suggest that there is diarrhea. And especially if patients are complaining of urgency, this loose stool becomes much more difficult to manage. But having looked at these types of stools, as I said before, we need to be aware of what is normal for that patient. As with going to the toilet, there are patients that only have their bowels open once a week. If it's all that they have ever had their bowels open for once a week, just because we'd like everybody to go 3 times a week and pass a good stool, it isn't normal for them. And so if they are not frequent in going to the toilet, it's just important to ask them what sort of stool they're passing. And if they're passing types 3 and types 4 stool, this isn't going to create too much of a problem in the future for their management. But once we've established that, there are treatments that we can try to help people manage their bladders. And one of the biggest ones is their dietary change. Just like the bladder, looking at what sort of foods and they eat, how much fluid they're drinking. So for diarrhea, for example, NICE would like us to keep up our dietary advice with fibre and eating your fruit and veg and things, but sometimes they might need to limit their fibre intake from being whole grain and bran, and use more oat type fibres to help with the bowel. They need to avoid eating potato skins and apple skins and things like that, things with pips in from the fruits and the vegetables, are often a little bit more difficult for people with loose stools for them to process, and they need to limit their dry fruit intake, things like that. Fizzy drinks and caffeine should be reduced, and avoiding high fat foods such as chips and burgers, because all of these things are more likely to give loose stool symptoms. So we don't want to make those things worse for people. And if people do have constipation issues, we can look at high fibre diets for them. So these are the people that should be eating all their fruits and vegetables and skins, and beans and whole grain rice and whole wheat pastas, wholemeal bread rather than white bread, and fruit, seeds and nuts, things like that. Can often. It's also worth looking at their fluid intake. Are they drinking enough? Sometimes people are constipated because they're not actually drinking enough. So it might be that we do actually need to look at their fluid intake in advising to increase what they're drinking, just to help soften that stool. If it's not dietary advice that can help, we can look at bowel medications for people. Loperamide is something we would use commonly to help firm up stool for people with diarrhea. So if they are going to a wedding, for example, they might want to do that and just give themselves a bit of constipation so that they can hold on to their stool a little bit easier, if need be. Just for that short period of time. And obviously, if they're constipated, we need to look at laxative medications, enemas, things like that, to help manage that constipation, help to loosen the stools. But you can have bulk-forming laxatives that will help with these things. We do need to continue to look at the pelvic floor for patients with fecal incontinence, and we can use this to try and help bowel incontinence by helping them to try and control the pelvic floor muscle to hold any incontinence. Bowel retraining is used to help with reduced sensation, and often we'll pop a small balloon for people with nerve damage into the rectum, and the physiologists will usually teach patients how to pass that balloon even though they can't feel it. So there are 3 goals within bowel retraining. That's to, 1, improve the stool consistency, which hopefully you've done already above. Get them to establish regular emptying of the bowel times, regular patterns of having their bowels emptying, and see if there's a way that they can stimulate the bowel themselves to make them have their bowels open. And like I say, if that's not, suppositories and enemas are effective, and you can have rectal irrigation. You can have, depends on their incontinence, but you can have low volume, small combs, or the full rectal irrigation systems in order to make people have their bowels open if they've not got sensation, not got the muscle control, and have constipation issues. So bowels are a little bit more impacted on the lifestyle, I would say, and on the social aspects, but they have much less of an option for management. But if we can get their lifestyle sorted, often people cope really, really well with it. Next slide. So I think this is the end for me. So I think from all of these things, we have looked at the fact that there are treatments out there for men, for both bladder and for bowel. And we as healthcare professionals need to become more confident in promoting the issues around male incontinence. And not just letting it become a containment issue. And we need to look at, it's not just old men, there are younger men out there with various conditions. They might never have become continent as children, and it's crept into adolescence and things, and we need to be more proactive in looking at this. And then research and proactive strategies need to be there to help improve raising awareness, for one, and improving the options. And the more we can find out about these things and how it's there, the more we hopefully in the future are going to have to offer as choices for these gentlemen. I think whether it's men or women, there is a great need to raise the awareness of bladder and bowel health. But socially, the media, the posters, and the health professionals, we're all used to telling ladies that they can get help from this. And I think we just need to be telling these men that when they come into clinic, yes, this isn't normal, might not be able to make it perfect, but we can definitely help improve it for you, and that there is a need for more education for men to be able to health promotion education, for them to be able to manage and perhaps pick up some things without necessarily having to discuss it with them. And I think in the men's magazines, especially for the younger men these days, this is becoming more over time. But there is still a lot more we can do this. And we definitely need to ensure that men with complex needs are referred to specialist services. Be it bladder or bowel, that they do need the multidisciplinary team approach. They need to perhaps be a little bit more investigated. Men with urinary tract infections need investigating. Men with hematuria need investigating. Chronic retention needs investigating. And there isn't enough out there for us to be able to. And I think if we use the specialist services to help get that out, I think it will help with the health promotion, because gentlemen really, we all know they're not very good at bringing their problems to the table, but I think if we can get it out there so that they see it, then more likely. So yeah. That's it from me, I think, and I'd like to thank you all.
Following on from Ruth's excellent session, I would like to take you through the products and support materials ST have to offer men for their continence needs. Next slide. With the ageing population, demand on continence services is growing. Often incontinence is regarded as a female problem. Prevalence figures do show that this is more common in younger women than men. But as people age, the difference decreases. Despite this, there is little practice guidance addressing male urinary incontinence compared to that of women. Differing approaches should be considered in order to meet male behaviours, attitudes and needs. Next slide. Tenor have designed a product range that are specially engineered for men. Tenor Men provides a solution that millions of men of all ages trust to stay dry, confident and in control day and night. The range extends in absorbencies from the light protective shield through the absorbent protectors of level 1 to 3 to the Tenor Men Premium Fit and Active Fit pants. New to the range for 2022 is the Tenor Men Washable Protective Boxer. These have been designed for light drips and smaller urine leaks and can be washed and reused over and over again. Next slide. In addition to the products, Tenor offer a wide range of support and educational material that is free to access on tenor.co.uk. This ranges from self-help guides, continence promotion material, and tips on helping to break the stigma of incontinence to gain confidence and to seek advice. Next slide. Tenor Community on Facebook is another avenue which offers support and education, helping the gentleman make informed choices on managing incontinence. Next slide. This year we have launched the Tenor Professionals Facebook page. This page is specifically designed to help those working in continence care. It provides easy access on information on the latest guidelines related to continence care, product information, and upcoming educational events. Next slide. Brand new from Essity is our gold standard education platform. This pulls all of our educational material together. Essity has to offer a diverse selection of therapy areas in one easy access platform. Learning styles include bite-sized training, webcasts, e-learning, and masterclasses. It allows the healthcare professional to pick their own educational journey, which best fits their needs, enabling them to meet their continued professional development requirements, and also supporting best practice. Next slide. For further information, please visit the highlighted booths in the Learning Zone section. Thank you.
Good evening, everyone, and welcome to the live element of tonight's event. As I said at the start, my name is Steve Ford. I'm the editor of Nursing Times. I'm delighted that joining us are tonight's speakers, Ruth Broom, Urology Specialist Nurse at Norfolk and Norwich University Hospitals FT, and Laura Elsgood, Nurse Clinical Consultant at SFT. Fascinating presentation, Ruth. Thank you very much. So, audience, now is your chance to ask any questions that you have on care or treatment linked to male incontinence. We've got around 10 minutes, so please get your questions or views in using the chat tab in the swap card, and I'll ask them for you. And we've already had a few in, which is great, so I will kick off, basically. First of all, Shayla Kumar has asked, are there any bladder training pathways besides lifestyle and avoiding deferral?
You can go down the route of time voiding, but it is that lifestyle and habit forming of going to the toilet for bladder retraining and for bowel retraining, the same. It's helping people to have the confidence to defer going to the toilet, and you can either do that slowly by postponement, or actually do for patients that don't get sensation to go to the toilet by giving them a timed voiding pathway. But I can't say that I've ever heard of a pathway that's not bladder retraining of lifestyle and dietary advice.
Great. Well, thank you very much for that. Where should we go next? Let's go to where should we go? Let's go to Emily Osborne. Okay, so Emily says the terminology in the article. So this is the beginning, I think. Is there anywhere on file where I can look into these area further as a first year? So I think this is referring to the information you did at the beginning. So basically, just looking for some good references. I think that might be one to well, we can pick that up afterwards, or any good idea.
Yeah. So I mean, the most up to date information is from NHS England in 2018, really, and that was continence care in the NHS England. There's lots of very good references in there. Lots of continence references are quite old still at the moment, so I should think rather than give you a big list, if you go to NHS England documentation, it will be there, and obviously the NICE guidance. There's NICE guidance for continence for bladders and bowels, males and females, that have only also recently been updated in the last year or so. Bowels are a little bit behind, I think, still, but bladders have definitely been updated. Female one was last year.
Fantastic, thank you. Yeah, we're getting a lot of questions in on guidelines and things like that. So another one from Shayla, in fact. So this caught my attention as well. Actually, the pelvic floor exercises. Is there where should we signpost patients for pelvic floor exercises for men, basically?
For men, so most continence services will have physiotherapy, if not within their service, attached within their services. And I mean, in the community where I am now, we have a physiotherapy team that deal with male and female pelvic health. But when I was in the Norfolk and Norwich in the hospital, we did have some of our women's health physiotherapists did have an interest, so it might be worth asking your female pelvic health colleagues if they know of any of their colleagues that are interested in male pelvic floor. But yes, there were only a couple of them. I don't think they're a huge population.
I can imagine. Yeah. And yet another sort of one on a similar area, I suppose. Louise Remington wants to know: are there any really good assessment plans? So examples of assessment plans that she could possibly
what
use.
Assessment tools for assessing incontinence. There are, there are. There's the bothersome schools and the lifestyle schools, but I personally, for when I'm teaching continence assessment, I tend to follow the collie model, which is just for bladders mainly, but that's a good pathway. You can go into the Coley model online and click the boxes, and it will take you through and guide you through, pointing you in the directions of the different types of incontinence, and to get how to, where to get help. Can you just go through pelvic floor? Should we just talk to this patient about some fluid management? Do we need to consider surgical options for them?
Great, thank you very much. So, a question from me. So, you said at the beginning that obviously men tended to get a bit forgotten, and I know you touched on it. But would you mind sort of explaining a little bit more why you think that is, and essentially how we improve things?
I think they do, because there's a lot of information out there for ladies. There's lots of support for ladies and health groups, and I think males in whatever their problems are, because they do tend to keep it themselves. It takes a lot for some GPs to go, for some men to go to their GPs and actually tell people there's a problem, that they're there. And then when they do get there, if they're elderly gentlemen, they say they're getting up at night. I think we do tend to say, well, it's your age, you can expect to get up at night, or they'll say it's your prostate. Well, just because you've got prostate problems doesn't mean you have to have incontinence problems. And the younger lads, I think they tend to hide it away. That it's a big social stigma, and I think in whatever men's health arena we're talking about, although things are improving, I think we still have to do a lot of work on getting men to not accept this problem. They've accepted it. They're hiding it or not talking about it. But get them out there talking about it and actively seeking some help. And then when they do go for seeking help, as health professionals, I think if you don't know what to do, sometimes we tend to play it down and say things like, well, it's normal, it's your age, yes, your flow's really poor, it's your age. It doesn't have to be.
Great, thank you very much. And one from David Newton. This is quite an overarching question coming now, sort of thing that I'd end the session with. He says, what one change do you think we should all try to action to improve care for our patients with regards to bladder and bowel continence? So, one thing, if you could get everyone to improve care.
I think once a gentleman, be it a teenage boy or be it an 80-year-old man, once they've actually sought that help, we should ask them, what is that most bothersome thing? What is the one thing you'd like me to try and help you with today? And concentrating on that one thing. They might have 10 problems, but let's pick one of them and try and solve one of them and give them something positive to work to, rather than, and like I say, just giving them a pad and telling them the little bit of leakage they get after they've walked away from the toilet is normal. Just wear a pad and hide it. We do just need to be more aware that it's taken a lot for these men to come forward quite often, and so I think we need to get their confidence in that it's something we can do to help them.
Great, Laura, you're nodding there.
Yeah.
Chime with what you think.
So I would say continue breaking down the barriers as continence or incontinence as a taboo subject. So let's talk about continence more, and equally incontinence. let it not be a subject that people are shying away from talking about, because we know that incontinence affects so many different areas of that patient's life. So if we can get those conversations flowing and not being an embarrassing topic, then I think it'll have a good knock-on effect with the end user.
Great, thank you very much. Just another question that occurred to me. So Ruth, you referred to the ICS guidance, and obviously you mentioned again, you mentioned things like NHS England and NICE as well in there, as you'd expect. Do you think the awareness amongst most nurses is high enough of the ICS guidance? Do you think?
No. I think perhaps outside of the world of continence, they don't know about the ICS guidance. They'll know about NICE, but I truly don't think nurses outside of the bladder and bowel arena are aware that we do have international continence society. We have a UK continence society, and I think sometimes it's perhaps because continence is this taboo subject. It's not just taboo for the patients, is it? It's something taboo that the nurses don't talk about, and they don't know what to do with it, so they just don't ask the questions sometimes. So perhaps as societies we should be getting out there more and promoting ourselves to other health professionals.
Great. Well, thank you very much. The time has whizzed past, as you would expect. So thank you, everyone. Basically, we've run out of time now for this evening. So thank you very much again to Ruth and Laura for sharing their expertise, and to ST for sponsoring the event. Hope to see you again tomorrow for the next of our webinars in support of World Continence Care Week, when we'll be looking at continence and transgender people. So don't forget, you can watch back all of this session and any of the other webinars in the series. So basically, goodbye for now and enjoy your evenings.